So today's talk will be about sleep, and at least its relationship with dementia and the importance of it overall. So a few things that we'll outline here. So I have one slide that I added from last time on just the importance of sleep. We'll look at obstructive sleep apnea, both the prevalence and kind of what the treatment options are, at least in today's landscape. And then we'll kind of tie in how these things are related, both any neurodegenerative disease, including Alzheimer's disease and sleep disorders. And we'll also look at some of the medications. I took out restless leg syndrome for time purposes, but we'll get through most of this. So I don't know if any of you guys have seen this, but this is like a pretty interesting U-shaped curve that came out of the Framingham study. So following people over long periods of time, and they did sleep questionnaires, and I don't know who's getting 2 hours of sleep at night, but we know that's harmful. But what's pretty striking is so if you sleep too much throughout the day, then that can be a cause of all-cause mortality. And I think there's a lot of things to potentially glean from this. My thoughts is more of this quantity versus quality problem, right? So if somebody is needing a lot more sleep, it's probably due to poor sleep quality and sleep efficiency. And so, you're needing more sleep to make up for that poor sleep quality. So both sleep apnea and neurodegenerative diseases contribute to poor sleep quality. So I suspect there is some relationship there. So let's do a case real quick, and we'll highlight some of these things as we go through. So the first case is a 76-year-old who comes in with 3 years of progressive memory problems. Her husband mentioned she's got significant irritability. Some days are better than others, so these sort of day-to-day fluctuations. She's got a history of hypertension, which has been pretty hard to treat, as well as atrial fibrillation. Her BMI is normal. When you try to do like a review of systems, you can do this Epworth Sleepiness Scale, EPSS. She doesn't really report any significant daytime sleepiness. On a little bit more sleep history, her husband mentioned she snores on most nights, sometimes heavily. She's waking up some nights with night sweats, and she's got increased urination throughout the nighttime. On neuro exams, pretty normal. She's got this, basically we can do a sort of an assessment for obstruction in the airway just by looking in the back of someone's mouth, and she's got this class 3 here score. And then you do a cognitive screening. She came in for memory problems, obviously. And she scores right around the mild dementia range at 26 out of 38 on our short test of mental status. So she's missing points on attention and on memory. So we've got someone that's got some mild dementia, potentially some sleep issues going on, but they're subtle if they're there. You want to get an MRI scan to assess for potential contributors to dementia. She does have moderate vascular disease present, so there's quite a bit of white matter changes here. That's what these little white spots are indicating on an axial slice of her brain. What are some of those risk factors? Well, we know about high blood pressure, which she has, right? High cholesterol, diabetes, smoking, but one that often gets missed is obstructive sleep apnea, right? So that's one that we have to think about. When we look at our memory structures, so here's the eyeballs here, the front of the face. Right around here is where we're looking at the memory structures. They actually look pretty good for her age. I don't see any obvious shrinkage. She's got these little perivascular spaces. So this is something I've kind of picked up on. And I look at thousands of these scans, right, with patients, and these little black dots here are kind of like small collections of spinal fluid. And that is potentially one of those things that can link to sleep apnea in my experience. So we do a home sleep study, and this is what like a result looks like with a home sleep study. This is way too much information. You can spend a whole talk on all the stuff we collect, even with a simple home sleep study. But basically, we're looking at this top box. We're looking for drops in oxygen saturation, and then it classifies whether it's an apnea or hypopnea, and whether it's obstructive or central. We can detect body position with an accelerometer. We can detect whether it's sleep or wake. We can look at the heart rate, which sometimes jumps up when somebody goes through these apneic spells. So is the blood pressure if we were to monitor that. And then there's snoring that gets recorded in this too. So we get a lot of information with the home sleep study. So this was her results. She had an AHI, so it's apnea hypopnea index of 33. On her back, it was 42, and even on her side was still high at 31. This is consistent with severe sleep apnea. So anything over 30 is severe sleep apnea, 15 to 30 being moderate. There was no clear positionality here, and she had some obstructive and central sleep apneas. So referred her to our sleep specialist. They did an in-house polysomnography and basically switched her from CPAP to BiPAP because of the central sleep apneas present. The some of the sometimes we get questions, well, should all home sleep or sleep studies be done at home? And there's lots of benefits to this. You get to sleep in your own bed, right? If you look at a lot of like long-term sleep studies, they throw out the first night because of that brain vigilance in unfamiliar environments. So I mean, there's some reasons to think the home sleep studies might even be better. Most insurance companies are recommending them before the in-house ones, just from the from the cost perspective. But they're not right for everyone. So the accuracy is not quite as good, but it's still pretty darn good for the majority of your patients. When sleep apnea is mild, so sort of in that 5 to 15 range, especially around that cutoff of 5, you may have a false negative result because it's not quite as sensitive. So, we always recommend if the suspicion is high, or if there's any issues with technical difficulties, like your patient and family can't quite figure out exactly why a home study failed, then that's a reason to get, a standard lab PSG. The other issue with home sleep studies, at least currently, is they cannot capture REM sleep behavior disorder. They don't have the EMG leads that can be done in-house to look for acting out dreams at nighttime and sort of muscle movements when someone's in REM sleep. So if you're looking for that, you can't use a home sleep study, at least most of the standard ones. And then you miss out on some of the EEG leads. So if somebody's got potential frontal lobe nighttime seizures, you're going to miss that with home sleep studies. So the prevalence of sleep apnea, it really varies depending on the study population and your definition of sleep apnea. The general consensus is it's more common in men. It gets more common with age, and obviously, one of the major risk factors is being overweight. There's all sorts of different studies from the 90s to more recently 2008 timeframe and even a little bit further. But if you look at men and women, the overall prevalence is quite high. This OSAS is like, do they have daytime sleepiness? So you can see like over half of individuals don't necessarily have daytime sleepiness, even though they have OSA found. Current estimates right now are that, like, at least in the United States, that about 26% of adults age 30 to 70 have sleep apnea, and that's number is even higher in age 70. That number is increasing as weight increases as well. And sleep apnea and Alzheimer's disease coexist. So, how do these things coexist? Well, in some ways, there's actually a bidirectional relationship here. So, the idea that if a patient is diagnosed with Alzheimer's disease, they already have fragmented sleep and less slow wave sleep. That's part of the Alzheimer's disease process. One study that looked at just kind of took patients that had mild or moderate dementia due to Alzheimer's, found that 90% of them had sleep apnea. Obviously, a large thing here of chicken or the egg, right? But 22% were mild, but most were in the moderate to severe sleep apnea range. When you look at kind of the symptoms in this study, this was with 100, I think it was 130 individuals. Most of them had an Epworth sleepiness scale score of 5, which is technically normal. We generally suggest over 7 and certainly over 10 being more abnormal. 90% had nocturia symptoms, and then the majority had snoring as well. So I have a pretty low threshold in my clinic to check this just due to this bidirectional nature. what we find too is that sleep disturbances are probably one of the first things that happen well before cognitive symptoms. So if you look at the literature of neuropathology, and some people have studied from age 30, 40, 50, 60, 70, right? One of the areas that tau actually accumulates first is down here in the brainstem in the locus coeruleus. And so we have this staging of tau that is well documented in the literature. But even before Braque 0, which is kind of like first thought of as the first stage of Alzheimer's, there's accumulation in these brainstem neurons, and we start to see sleep disturbances along with neuropsychiatric symptoms well before the cognitive decline sets in. One study found, looking at across the lifespan, tau is present in almost 100% of us in the brainstem by age 40, right? So we're talking about diseases that span across multiple decades with Alzheimer's disease, but there's changes happening in this important sleep regulating and wakefulness regulating structure well before cognitive symptoms set in. Additionally, so amyloid plaques, are related as well. We know that if patients have excessive daytime sleepiness scores, that are elevated, they overall have higher amounts of amyloid plaque accumulation. And when we think of amyloid plaques building up over time, 5 to 20 years before symptoms, there's probably some relationship here as well. We also know that insomnia and significantly reduced sleep time and increased wakefulness throughout the night is associated with amyloid plaque accumulation. And sort of remember that U-shaped curve from before, right? There's probably a relationship here even with Alzheimer's disease. Sleep apnea is associated with increased amyloid loads, and the thought here is that it's a decreased clearance problem. So when what we've learned about spinal fluid clearance really over the last 10 years or so is it drains from basically the arteries to the veins. So like all neurons have spinal fluid around them, and it's called interstitial fluid, and it basically filters through and washes out. And we go through this washout period to try to get rid of all the junk. What are some of the ways that disrupt this? Well, inflammation from reactive astrocytes. If you have amyloid plaques developing, if you have damaged neurons, these are all things that can disrupt this flow. And then you get impedance of clearing the proteins and the protein waste that builds up. And so basically what disrupts this flow is what's depicted on this cartoon here. And we know that reductions in slow wave sleep are related to incident dementia. So if you follow people that have significantly reduced slow wave sleep, then they are at higher risk of developing dementia. And part of this is probably the disruption of this glymphatic flow like we talked about. So what are some other things? So aging, here's a nice depiction of if high glymphatic flow occurs most in this in REM 3 stage, which is our deep sleep. When we're young, it is drastically reduced when we get older. And so that's aging being one of the major risk factors here. But Alzheimer's disease also disrupts stage 3 of sleep, and so does sleep apnea. So when you have all three of those things co-occurring, that's where you are going to have major problems. Obviously, we have to focus on what we can treat, right? Can't treat aging, and we don't have a cure for Alzheimer's yet, but we can treat sleep problems. So this patient, back to our case, so they were titrated, and I should have put BiPAP here, but essentially we were able to get them down to an AHI of 5, has been wearing the machine regularly for the last 12 months. On follow-up, the score improved from 26 out of 38 to 32 out of 38. So it's still abnormal, but it's more in this mild cognitive impairment range. But extended follow-up, so 2 years later, so now we're 3 years after the initial visit, memory and daily functioning have significantly worsened to the point where they're needing assistance with most daily activities. And you learn that they had stopped their machine about 8 months prior. They didn't really notice any benefits, so they stopped using it. And now their cognition is 19 out of 38, which is more of a moderate dementia range. You repeat a scan, and it looks like this. So we're starting to get shrinkage of the hippocampal structures. You're starting to get thinning of the temporal lobes. You still see some of these perivascular spaces, just to compare, right? So we're getting a lot of atrophy within the temporal lobes here, and it correlates with this degree change. When you look at CPAP usage and dementia risk, so in a Medicare beneficiary study, a large study, obviously retrospective, those that were in the quote unquote adherence group had a decreased rate or odds ratio of dementia. Now, this adherence group is a very low threshold. Is to meet that, they only need to refill their equipment 2 times over 3 years. So I think if you had a more stringent criteria, these effects could even be higher. But the same was, so that was all-cause dementia, and same found with Alzheimer's dementia, that sort of MCI to dementia progression was less in those that were treated. But we all know about CPAP quote unquote failures. Actually almost 1 in 2 individuals will quote unquote fail CPAP. I think a lot of this starts with counseling. So there's a certain percentage of individuals that notice the benefit so much with their CPAP they will never let go of it, right? They travel with it, they do everything. If they would not even take a nap without it, right? Unfortunately, that's not the majority of individuals. I'd say it's probably a quarter or less. And then there's like a quarter of folks where it's just like they're never going to tolerate this. They don't sleep with it. And it's just never going to be a realistic option for them. For a lot of the people in the middle, it's just really highlighting that importance for brain health, reducing the risk of all-cause dementia, especially in those that have mild cognitive impairment. And I guarantee you adherence will go up if we highlight those factors. Other reasons why these fail is, well, not using it. So 4 hours per night or 70% of the time. Sometimes it's nasal issues with deviated septums. It's sometimes congestion, claustrophobia, right? These are all potential contributors. So if my patient stops CPAP, for those that have mild or positional sleep apnea, a body pillow or some sort of wedge pillow can be helpful to keep them on their side. Weight loss is obviously one that can help at least the severity of the sleep apnea. We have new weight loss medications. Everyone, if you give them the option, everyone will choose, well, no, I'll just try to lose weight with exercise and diet. And then we'll see you back in 6 or 12 months, right? That the success of that is not high. For those that are really high BMI, even bariatric surgery has been recommended to some patients. You can get a dental application. One of the issues with this is cost. And the other issue is that dental application can sort of loosen over time, and so it does need follow-up. And oftentimes, you'd want to do some sort of remote oximetry study to make sure that it's working as well, just since it's not the gold standard treatment. Some people can undergo surgery, but obviously as you get older, healing from this can be an issue. And then there's the new Inspire device. So what does this look like? It's basically like a pacemaker for the airway. So it can help protrude the tongue and then help keep the airway muscles open throughout the nighttime. One of the issues with this is it does require a surgery, right? So anesthesia, and it also includes that in sort of looking at the eligibility. So in my patients with cognitive impairment, I'm not like overjoyed about having them undergo surgical procedures, but we've done it multiple times in our clinic and it's gone well. And if you've got somebody that has moderate or severe sleep apnea, the risk to their brain of not treating it is higher than the potential risk of a surgery. Is kind of how we've looked at it. You have to meet certain criterias, so there has to be a whole process to see if someone's eligible for this. All right, case number 2. This is a 68-year-old gentleman. He's got progressive cognitive concerns. He gets detailed neuropsychologic testing to look into memory changes. He's diagnosed with major neurocognitive disorder, which we've said is basically a mild, or is a dementia range, but he's having executive, visual spatial, and memory domain impairment, so multi-domain impairment. On history, he's got this past medical history of insomnia, sleep apnea, but he's not using the CPAP. He's also got severe REM sleep behavior disorder, so wife doesn't even sleep in the same room as him anymore. Constipation, lightheadedness, daytime sleepiness. Sometimes he sees shadowy figures out of the corner of his eye. Um, so hopefully, we've talked about a similar case in the past. Those of you that have seen that, hopefully you're recognizing what the diagnosis might be. If I tell you he's also got on his neuro exam some decreased facial expression that we call masked faces, decreased arm swing on the right, hopefully your brain is going towards this patient has probable DLB or dementia with Lewy bodies, where one of the biggest indicators here is this severe REM sleep behavior disorder. Now note, he's been on donepezil, but it's at bedtime, and he's also taking Tylenol PM at bedtime. So what's some of the issues with that? Well, when we look at REM sleep behavior disorder, this is a key question to be asking. And you can't ask the patient, you have to ask the spouse or bed partner, because if they're sleeping, they might not have any idea. But the brainstem nuclei that are affected very early on in Lewy body disease are basically important for muscle tone paralysis while you're sleeping. So you're supposed to be paralyzed while you're sleeping, and damage to these neurons can contribute to this REM sleep behavior disorder. Donepezil at nighttime can exacerbate REM sleep behavior disorder. So it's not uncommon that we hear, oh yeah, well, the doc started donepezil and then I really had nightmares and bad sleep going on, and then I had worse behaviors during the day, and the medicine was not helping, so we stopped it, right? And that's not the right thing to do in this scenario. You need to move it to the morning with breakfast. When that drug peaks throughout the day, that will help them with their cognition, and then they're less likely to have these nighttime side effects. Melatonin is very reasonable to start in most of these patients. It does suppress the amount of REM sleep, and I'd say it works in about 40 to 50% of cases, depending on the severity of the REM sleep behavior disorder. And we don't have any significant cognitive worsening associated with melatonin. I put 15. I generally stop at 12, but that's variable depending on the provider. We always start low and go slow with anything that we do. The other option, so let's say melatonin doesn't work, you still might keep them on a moderate, a reasonable dose, 3 to 6 or 9 milligrams of melatonin, but then add in clonazepam. And this is not something that we like to give patients with underlying dementia, right? But if somebody's at risk of injuring themselves or their spouse, they have severe REM sleep behavior disorder, this works very well even at low doses in most patients, right? So everything that we do in medicine involves a risk-benefit discussion, and this works quite well and is a option that can work for REM sleep behavior disorder. When you look at melatonin, like over our lifespan, right? If you Google this, you'll find some pretty interesting looking graphs. So Dr. Google says melatonin really plummets throughout time. I would argue it's probably closer to this, where there is a peak effect loss throughout the nighttime. And why might that be? Well, the way the melatonin production works is basically if you have decreased incoming light, which our screens and everything might be an issue here, but that triggers from the pineal gland to produce melatonin, which is part of that circadian rhythm to help you promote sleep. But what happens with aging is this pineal gland calcifies quite a bit. I always tell the residents I could probably guess someone's age based on how calcified their pineal gland is. And so obviously there's going to be some change in melatonin production with age. When we look at insomnia, so, the overall message of this, especially in individuals with memory disorders, folks that are at risk for developing dementia age 65 or older, we do not recommend benzodiazepines or anticholinergics, except for that clonazepam example I gave you. So common ones that we see over the counter that might not even be on their list, right? Benadryl, sleep PM drugs that have diphenhydramine in them, or any sort of first generation antihistamine, amitriptyline, nortriptyline, Ambien. So in general, first line should be melatonin. That's not going to work for people that have been taking these strong drugs for 10, 20, 30 years, right? I think it's still probably important for most people with insomnia to have some supplementation of melatonin, but you're likely going to have to add in something else. We generally like trazodone for that, just from the cognitive side effect perspective. It doesn't really have any significant cognitive side effects. Another thing to think about, if they've got a lot of mind racing and anxiety that's contributing to their insomnia, then just a basal, daily SSRI can be helpful for those folks. Mirtazapine is reasonable. You want to use low doses for the sleep effects of 7.5 to 15. There's some mild anticholinergic effects with this, but overall it's an okay option. And then you have the newer dual orexin antagonists. So these are newer and more expensive options, which I think are going to be pretty good options for a lot of people once cost becomes more reasonable. Here's 3 of the ones that are on the market now, and when they were approved, they basically work by preventing you from feeling awake. So the orexin receptors in the brain are key to feeling awake. So narcolepsy patients can have mutations and disruption of this orexin receptor, and that's why they can fall asleep at any point throughout the day. But if we block these, right, then you can help promote sleep in that way. And these have been studied in folks with Alzheimer's with really no significant cognitive side effects. We need some larger studies, so I say should be for now. In animal models and even in people where we've looked at amyloid and tau throughout the nighttime, there might be improvement in Alzheimer's biomarkers with these drugs too. So we'll need some more research into these, but these might be good options for the future. If I'm going down this path, I'm usually getting a sleep consult, right? If melatonin and trazodone are failing. Better than any medicine is sleep hygiene, which is really not good for the majority of the United States and really across the world. So, a very simple 3-2-1 sleeping protocol, not eating 3 hours before bed, not drinking 2 hours before bed to reduce some of that nighttime urination issue, and then no screens to help melatonin production an hour before bed. We should be aiming for 7 to 8 hours of sleep. And trying to avoid naps after 3 p.m. Obviously, only if that's what's disrupting your nighttime sleep. Exercise can really help, but obviously not too close to the sleep time. And so I think all these other ones are pretty self-explanatory, but these are all self-explanatory, but a lot harder to do in practice, right? But if you've got insomnia, or your patients have insomnia, they need to be focusing on this. I mean, sleep is medicine here, right? And they have to make that a priority. And they can't expect a pill to solve everything. For daytime sleepiness, because that can be an issue, right? Well, the first one is to treat the underlying sleep apnea because they're not having efficient sleep. The other things that we'll recommend can be modafinil. That's my preferred agent for like our second case there of Lewy body disease. There are a number of other potential stimulants out there. And then there are some really newer drugs that can help with daytime sleepiness as well that might require a sleep consult to think about those. All right, so I'll wrap up here because we're right at time, and then I'll try to answer a few questions. So sleep problems are highly prevalent in neurodegenerative diseases. There's a very large chicken or the egg question there, right? But probably a bidirectional effect. Sleep apnea is associated with poor CSF clearance. Lewy body disease, of all the different neurodegenerative diseases, has the highest cause of sleep contribution of sleep disorders. REM sleep behavior disorder being present in over probably 90% of individuals, and then sleep apnea being second, insomnia, daytime sleepiness. I don't think I've ever met a patient with Lewy body disease that didn't have some sort of sleep problem. Alzheimer's disease and sleep apnea have a bidirectional effect. I just mentioned that. But this sort of idea that aggressive sleep apnea treatment early in life, it's a vascular risk factor for the brain. It's a heart attack and atrial fibrillation risk factor for the heart. It is a risk factor for amyloid plaque accumulation. And so, I think as a primary prevention strategy, that's something that we definitely need to take more seriously.